Okay, here we go. We're going to be getting started in just about a minute. Right now, you'll see some messages from our sponsors. And I encourage you to get your questions ready. You can enter your questions in the question and answer section because we have a great panel of experts who are ready to answer your questions. So if you've got any burning questions that you've wanted to ask experts,
I just wanted to see if you
please go ahead and write them in the question and answer section, and we will certainly get to them. This is an interactive session, and we want to make sure that everybody gets the answers to the questions that they have.
To see if you're an attendee. You're actually signed in as an attendee. So let me see 1 second if we can promote you, but bear with me because I'm going to have to hold on for just a second. I'm multitasking too, so bear with me for just 1 second.
All right, so we have one more person who's going to join us. Let's see.
Focused on transforming care delivery to improve quality of life for patients globally. The company is the largest provider of kidney care services in the U.S. and has been a leader in clinical quality and innovation for 20 years. Through DaVita Kidney Care, the company treats patients with chronic kidney failure and end-stage renal disease. DaVita is committed to bold, patient-centric care models, implementing the latest technologies and moving toward integrative care offerings for all. As a community first and company second, DaVita believes in supporting organizations that make a difference in our communities. To learn more, visit davita.com/community.
Okay, thank you, DaVita, for being one of our valued sponsors. And thank you to the participants, to my panelists. Thank you for being patient. You know, there's sometimes technical difficulties, but we are adjusting to these difficulties day by day with this new life that we're living. So welcome to our virtual Living with Kidney Disease and Transplantation expert panel. I'm your moderator, Monica Fox. I'm the Director of Outreach and Advocacy at NKFI. I'd like to start out by thanking our sponsors for making this virtual event possible. Our sponsors are DaVita, Baxter, CareDx, Fresenius, Kidney Care, Gift of Hope, Organ and Tissue Donor Network, Loyola Medicine Transplant Center, Northwestern University Medicine, Rush University Transplant, and UChicago Medicine. Before we begin our session, here's just a few reminders. All attendees are in listen-only mode. Since this is an interactive session, we encourage you to use the Q&A box to ask questions for our panelists. If you're having any technical difficulties, please use the chat box and one of our NKFI staff members will attend to your concerns. This session is being recorded and a recording will be released later in the week. It is now my pleasure to introduce our speakers for this evening's session. Our panelists today are Dr. Amishi Desai, a transplant nephrologist at Loyola, Dr. Stephen Jensik, a transplant surgeon at Rush University. I think Dr. Jensik is still trying to connect with us. Dr. Anesia Reticker and Dr. Benito Valdapenas, pharmacy residents at UI Health, Brett Burrows from the University of Illinois, Grace Mooney-Melvin, a social worker at Northwestern Dialysis Center. So without further ado, let's begin today's session. So I would like to start by asking our panelists to just to introduce themselves, tell us a little bit about themselves, and maybe add something interesting to it, like how you're coping with COVID-19. So let's start with Brett.
Hello, my name is Brett Burrows, and I'm a fourth-year PhD student at the University of Illinois at Urbana-Champaign, and by trade, I'm an exercise physiologist. And in our lab at University of Illinois, we deal mainly with hemodialysis patients and exercise and nutritional interventions to try to help improve overall health, physical function, and quality of life in dialysis patients. So kind of how I've been dealing with the coronavirus, it's certainly been day-by-day basis. I have a 3-year-old toddler running around, and my wife's 6 months pregnant. So it's been a struggle this week, particularly. I've gotten no work done, but no, it's going okay. Other than that, though. So.
Well, thank you, Dr. Desai.
Hi, I'm Dr. Desai from Loyola University. I am the medical director of both the kidney and pancreas transplant programs. We've definitely been struggling with the coronavirus, but definitely prepared here at Loyola to take on patients. And so we're just taking it day by day. As far as my personal life, I have a 10-year-old, a 5-year-old, and an 18-month-old. And certainly my husband has become Mr. Mom, and I've been here in the hospital. And so I spend my days looking at their beautiful pictures here on my desk and just can't wait to get home with them to spend some time with them.
Thank you. And thank you for being out there and taking care of the patients through all this. Grace?
I'm Grace Mooney-Melvin, and I'm a licensed clinical social worker currently at U.S. Renal Care at Northwestern Hospital, primarily with peritoneal dialysis patients and home hemodialysis patients, but have been in the dialysis field for about 7 to 8 years now. And to cope with the coronavirus, a lot of FaceTiming friends and Netflix and learning a few new recipes to keep busy on the weekends.
Awesome. Thank you, Grace. Dr. Reticker?
Hi, everyone. Yeah, my name is Anesia, and I'm one of the pharmacists here that works with the transplant team at the University of Illinois Hospital. Throughout this coronavirus, we definitely have seen a change of pace in the transplant team, a lot of telehealth, a lot of interactive ways I never envisioned practicing, but it's been an adventure. As for personally, I have been cooking like a lot of other people. Still haven't done a banana bread like it's all over social media, but having my fun with different things.
Great, thank you. Dr. Valdapenas?
Hi everyone, good evening. My name is Benito Valdapenas, and in similar manner, I'm one of the PharmD residents in solid organ transplantation here at the University of Illinois at Chicago. COVID-19 virus has never halted or has never impeded the world of transplantation, and here at UIC, we're still taking care of our transplant patients. In terms of our coping mechanism, watching a lot of Netflix, some running and walkathon and walking here and there. So, yep.
Awesome. Thank you so much. Thank you all very much for taking time out of your busy schedules to be with us today. It's so important that our patients have the opportunity to interact with professionals like yourself and get some questions answered. So let's just go to some questions right away. We'll just start with There's a question about exercise. Can exercise make me feel better?
So that's kind of a yes, it can, but not overnight. I guess that some individuals and in general, everybody wants to have a quick reaction to exercise, but unfortunately, that's not the case. It takes some regular exercise to get benefits, and those benefits can go from anywhere from 2 to 6 weeks to see those benefits. But yes, benefits of exercise are improved energy, increased mood, decreased depression and anxiety. So yes, exercise can definitely help with those conditions.
So that leads to the next question that says, I have no energy and I struggle to exercise. Do you have any tips? So what does a person do if they have no energy to exercise? How do you start?
Yeah, that is a very big issue, especially with dialysis patients. They go through dialysis session. They may have cramping, severe post-dialysis fatigue. The best thing that I try to suggest to our patients is to start small. I'm not looking at them to do some type of resistance exercise training program right off the bat, just trying to maybe get up and walk out to the mailbox more often. Very small things, go up a flight of stairs if they can, instead of taking the elevator. Just try to make more steps throughout their day. During TV commercials, get up and walk around the kitchen instead of just sitting there on the couch. So just little things like that can, if you do it progressively throughout the day, can start to make a bigger difference. And then you can start to see yourself do more throughout each day and start to see, like I said, it does take about 2 to 3 weeks as far as energy levels to start to see some type of improvement. So again, it's not going to happen overnight with your energy levels to start to improve. So it is going to take a little bit of time to see those, benefits of exercise.
Okay, great. Thank you so much, Brett. Here's a question that says, I'm scared of transplant surgery because I'm afraid I'll have complications. Do you have any advice for me? Amishi, would that be something you would speak to?
So, certainly there's always a fear of any surgical procedure. Transplant surgery in and of itself is a moderate risk sort of procedure. And I guess more specifically, if you had certain concerns, we could address it. But I think the end benefit to you once you come out of it, the complication rates are not as significant as other surgical procedures. And Dr. Jensik, if he's on, could probably comment more on what to expect post-operatively. Many patients, even on day one, if they're making urine, are elated, excited, they're happy to be off the ventilator, they're moving about. We actually have them walking in the unit and around the room the very next day. So as far as pain and stuff from the surgical procedure, yes, that's there. But I think what ends up happening to most of our transplant patients is they're just so elated to no longer require dialysis and be making urine that dissipates any of those post-surgical risks. If there's specific actual undergoing surgery sort of concerns, that's certainly something I would bring up with the surgeon that's going to be doing the procedure that day, or even when you come in for the evaluation. The surgeons do spend time talking to you about what to expect, what sort of recovery to expect. You'll be seen multiple times in the clinic by physicians, your nursing staff, and everyone that will help take care of you. So there's a whole team that's going to support you through it and make sure everything goes well and that the complication profile is minimal, and that you're up and running within the next 6 to 8 weeks, moving on to some normal lifestyle.
Great. Well, I would have to echo from personal experience exactly what you said. So I'm a kidney transplant recipient, and honest to goodness, the minute they took the ventilator out, my sister's words were, "You behaved like someone shot you out of a cannon." I was so excited that the transplant surgery had happened and I've been so excited ever since. Like, I'm just excited. So it's been
Amen.
an
We just
incredible
this
gift.
morning.
It was definitely worth the surgery. It is certainly a much better and different life than dialysis.
Thank you.
Dr. Jensik, welcome.
Yes, I apologize. I
That's
apologize for
okay.
being late.
No problem, no problem. We talked early about how we've adjusted to this new normal that we're living and having to do all our meetings virtually, and dealing with technology as it comes. So we're glad you joined us. I'll just ask you to introduce yourself, and then we'll resume the questions. So everybody just kind of said who they are, where they're from, what their role is, and how they're coping with COVID-19. As an
Well, my name is Stephen Jensik, and I'm one of the kidney transplant surgeons at Rush. And by coping with COVID-19, we're really not doing many kidney transplants at this time for a number of reasons. And I think all the programs in Illinois, I think, have pretty much taken the same philosophy that coming to the hospital for a kidney transplant exposes patients to an environment where there are a lot of patients with COVID-19 being treated in major medical centers and all the transplant centers. So the possibility of becoming secondarily infected is significant. In addition, should the patient have a transplant and be in the hospital for 3 to 4 days and then leave, the patients are highly immunosuppressed, especially after the transplant. And the risk of contracting COVID-19 on the outside is also higher, and it's a very serious risk factor for patients. And so most programs, at least for kidney, where it's not absolutely considered life-saving, in contrast to a liver or a heart, I think most kidney programs have pretty much curtailed their operations. Am I correct? There are individuals I see probably from other institutions. Am I correct, or are other institutions still doing transplants on a regular basis?
Dr. Desai, are you guys doing transplants over at Loyola right now?
So we are doing transplants on a case-by-case sort of selective basis. If you are a patient who this may be the offer that is one of those only offers for you because you happen to be sensitized and you may react to the majority of offers that are offered for you on the waiting list, then we would consider moving forward, and we check both the donor and the recipient for any COVID-19 transmission. And what we have incorporated is asking our surgeons many questions about your ability to undergo telehealth communication. What is your home care like? Who else is at home with you? What sort of risks would you have in this situation where we're actually all asked to stay at home and not to go out as often as we can or as we need to, especially to see physicians and to follow up on medical care? So since the lockdown, quote unquote, we have actually done about 3 transplants. One was right before that situation. One was a pretty standard case where we knew that the patient would be able to be making urine, was a smaller individual, wouldn't require too much in the way of staples or stenting. And they've been doing okay. And then we do our monitoring with the telehealth system. But there is always, as Dr. Jensik has mentioned, quite eloquently, there's a risk because you are immunocompromised. And at this point in time, per CDC recommendations, that puts you in a high-risk patient population if you were to contract COVID to have a more serious outcome. So we are being selective. In our living donor cases, we are not necessarily opening up just yet, but we are doing workups. We are doing telehealth new patient visits. Our coordinators are doing education sessions. So we're moving forward with things so that hopefully when all of this dissipates, we will be able to begin surgeries as long as the center has opened up for regular business again. But I echo what Dr. Jensik has said in that in life and death situations, yes, we are moving forward with liver, heart, and lung. In the kidney situation, we are selectively and cautiously moving forward is what I would say.
Thank you.
Could I ask Dr. Desai, what has been the experience with the patients who have been transplanted, who have contracted COVID-19 and I assume been readmitted to Loyola? This is sometimes a very serious problem for patients, and there have been patients at Rush who've died from transplant patients who were immunosuppressed who contracted the virus subsequently. Has Loyola, have you had a comparable experience where this is a major, major risk for patients who had already had a transplant and are on maintenance immunosuppression nevertheless?
You know, we have about 3 or 4 patients that are at home being monitored with COVID-19, so they have some mild symptoms, and what we've implemented is one of our post coordinators will call them, one of our post APPs will call them every day to check upon them and see how they're doing as they're being kind of treated at home and symptomatically staying at home. We have about 3 or 4 within the hospital, and then beyond that, I have lung patients as well that have COVID-19, as well as we've had some heart patients, transplant patients that we followed. I only have 1 at this time that's in an ICU setting, but the majority of them have been, none have passed or anything from that situation. We've been able to take care of them appropriately. We've reduced their immunosuppression. The graft is continuing to function. So I would say with that small N that we have, we've pretty much been so far successful. What we did implement before all of this is we did ask all of our patients to stay at home, encourage the telehealth visit, offer them lab scripts so that they could go to local Quest institutions rather than come on site on campus for blood draw. So we've been protecting them quite well, I would say, because we're not seeing so many coming into the hospital at this time.
Thank you. Thank you. That's good information and knowledge. And I think we could just have a whole panel discussion around that. And stay tuned, maybe we will. So I do have a question from Kevin Fowler. His question is about obtaining monthly labs. Kevin is a transplant recipient. His question is, are there any remote lab services, such as Visiting Nurses Association, that managed care plans or medical centers are offering?
So we have sent all of our patients scripts to go to local Quest facilities. You can call the centers locally, and many of them, just as we've noted with grocery stores and stuff, they have hours, especially the very first hour of their day, where they will allow for patients who are immunocompromised, patients who may be requiring chemotherapy, those at-risk patient populations, to make appointments so that they are not waiting with groups of individuals and having more exposure. The other thing we know from the Quest facilities is that none of them are COVID testing sites. And so that has ensured too, at least, that our patients aren't going to be going somewhere where it's a testing center where patients will be sick. And so that's what we've implemented for our post-patient population. There are certain companies that have moved forward with at-home transplant care. That would be company specific because they also require testing from their end, and some of that is bundled, and that may or may not apply to individually, but your center would know kind of what may fit for their post-care management.
Okay, thank you. There's a question here from Harry. He says, I'm a kidney and heart transplant patient. Is red meat harmful to my kidney? And are there foods that are beneficial for the kidneys? So I know we don't have a dietitian on today. The dietitian panel was on Tuesday, but anybody want to take a stab at that? Brett, you do nutrition too, or just exercise?
Yeah, we do a little bit of nutrition, but I would not feel comfortable suggesting about this one without the proper specific knowledge of, I know the dialysis versus non-dialysis CKD nutrition is a little bit different, so I deal mainly with dialysis patients. So I would feel uninformed to give some education on dietary recommendations for non-dialysis CKD.
Okay, thank you. Dr. Desai, Dr. Jensik, do you guys recommend or not recommend red meat post-transplant, or are limiting it? Is there a general rule of thumb about that?
I mean, I would advise everything should be just in moderation. It really depends too on where your kidney function is at in the setting of the heart kidney transplant. You know, a high protein diet may not impact your kidney directly, but we may see that there's excess protein that could be in the urine. But overall, I advise my patients on a moderate sort of heart healthy diet, and especially with a heart and a kidney transplant, I'm sure that what your cardiologist recommends would be the most beneficial overall. And then again, it depends on your kidney function, because if there's any chronic kidney disease component to your transplant, then there might be nutritional requirements that have to change based on your electrolytes and other lab values.
Okay, thank you. And for you, Dr. Desai, same patient. Harry is a patient at Christ, and his nephrologist is a Dr. Desai. Is there any relationship?
No, but I know Dr. Desai from Christ House. There's a lot of Desais. It's as if we, had the last name Smith or Jones.
Okay, all right. Well, he says he's excellent.
I do know who he is. And he is a transplant nephrologist, and so you're in good hands.
Okay, yep, he says he's excellent, so I think he feels like he's in good hands. Okay, Kevin Fowler gave a follow-up question that I'm looking for lab services that come to our homes rather than going to Quest.
So specifically, we have certain testing companies that are doing kidney transplant labs, and that would be the AlloSure company or Natera. They have offered that sort of home health travel nursing, where the nurse will come to your home and draw your labs for you. Now that would be center specific, because it would be something that your center may be participating in a study with that company, or they may have access to how to coordinate that for you. A specific healthcare group that would come and draw those labs for you, I don't have that information, unfortunately.
Okay.
And the National Kidney Registry, I'm sorry, is also looking to send nurses, travel nursing, that can go and draw your labs for you as well. Again, I would reach out to your center, because if they're affiliated with any of those, then they can help assist you in getting that coordinated.
Okay, thank you. Here I have a question for the entire panel. What is your top suggestion or tip for kidney patients who want to practice good health during the stay-at-home order while still engaging in good exercise, mental health, diet, medication consumption, etc.? So let's let the pharmacist start first with the medication piece of it. Anesia?
So what I would say, thank you, Monica. What I would say from a perspective of medications is making sure when you're getting to about 10 days left of medications, you have a reliable source in which you could pick up refills or have your refills delivered to you. A lot of pharmacies are waiving their fees associated with delivery and bringing the medication straight to the house, which can be really helpful to help minimize exposure. Otherwise, just always keeping focused on how much you have left of your anti-rejection medications, and being in touch with your coordinators and your pharmacists about if you are running low and struggling to get more, if there were to be in the setting of drug shortages.
Great, thank you. Ben?
With what my colleague, Dr. Reticker, mentioned about medication access, a lot of insurance companies are allowing 60-day, 90-day supply. So that's something that our patients should take advantage to ensure that they have adequate supply, especially in the context and in the setting of this potential prolonged stay-at-home order. Obviously, there are dire repercussions if our patients, run out of their medication, stop taking their medication. So that's one avenue that they can explore in terms of like asking for a 60 or 90-day supply to ensure that they have adequate supply of their medications.
Thank you. Brett, you want to chime in on the exercise piece?
Sure, thank you. So with the exercise, just some tips I would suggest. You can still obviously be very engaged in exercise while in the home. If you have the ability to get outside the home and do walking programs, that would be even more beneficial, but you can still be active inside the home. Get creative, try to set up a little space for yourself, whether it's a towel or if you have a yoga mat, you can set that up anywhere that you have space. You can use soup cans if you have resistance bands, hand weights, jugs of water. Those could be different things that you could use for weights. And I know that they have different apps out there that are free, and especially now with the COVID-19, that are at reduced price, that can kind of help you, guide you through exercise programs. And same thing with the mental health. I know there are some apps as well that are out there for kind of at a reduced cost during this time, that you can help do some guided imagery, meditation, things like that.
Great, thank you so much. Grace?
In regards to mental health, I think especially right now, depending whether you're a home dialysis patient or you go to in-center or you're not even on dialysis, it can kind of be an isolating time, being at home. So I think utilizing the resources, whether it be really utilizing your support system, obviously not in person, but by checking in on the phone, FaceTime, doing these kinds of calls so that you're continuing to kind of engage with the outside world and not just isolating and going down like the dark rabbit hole of reading the news about what's going on. And so utilizing that, I know a lot of counselors, if you are currently seeing one, are doing telehealth visits as well. So that's another resource to continue that follow-up if you are seeing a therapist of any sort, and really checking in via phone with those therapists, not just cutting off that service if you were doing that prior to this time. And then I tell for like my home patients is trying to kind of still keep a schedule of some sort. I know you're not able to do the same things that you used to, but whether it be going out for a walk, setting goals for the day so it keeps you feeling productive and not just sleeping all day. Instead, utilize your support system, I think, is the best way, but virtually at this time, obviously.
Great, thank you. Dr. Desai?
So I echo what everybody else has said. Just, I think the biggest components of staying healthy is mental health, making sure you're taking your medicines, following the recommendations of your physicians. Reach out if they have telehealth access or if they have whatever sort of platform they're using at their hospital that you could communicate with them. We have My Loyola set up for our patients. They can send us messages if they're struggling with anything. We're there to assist them. And so I think that that's the most important thing, is to kind of keep active, watch your diet, take your medications, and just try to do your best to stay healthy in the confinements that we unfortunately face at this time.
Agreed. Agreed. Yes. Thank you all. So there is a question from Facebook from Madeline. She says, my husband is a kidney recipient and he's freaking out about COVID-19. He's not sleeping. Is there any advice or words to ease his worry? Maybe Grace or anybody, go ahead.
Go ahead, Dr. Desai, if you want to go first.
Oh, I think it's natural to be afraid at this time. Obviously, as a transplant recipient, you're hearing all these things from the CDC that you're at risk because you're immune suppressed. You may have other health comorbidities, which has even led to you requiring dialysis at some point or requiring the transplant. So our patient population is certainly a high-risk patient population. But I think that if you're following the guidelines, you're staying safe, you're being cautious, you're doing just the same things we've always advised you. Wash your hands, don't touch surfaces and touch your face. We advise that whether or not there's a COVID pandemic or not. So just continue that. And if you've been healthy with that and you've been following that routine, that's going to get you through this, you know. And if there's a general fear of coming to the hospital or exposing yourself to, just express that to your care team, and they will explain to you how they can best take care of you from a distance, because that's our goal, is keeping you safe, keeping you protected. We know what you're struggling with and what you're going through. And so I would just say, keep up those good practices that you had even before all this happened.
Grace?
Totally. Oh, sorry.
Oh, go ahead, Anesia.
Oh, just one short thing. I totally would echo that and say that, honestly, in my opinion, some of our transplant patients are the most prepared because they're so used to doing these things of washing their hands, careful with what they're eating, careful where they're putting, you know, their belongings. And I think in a lot of ways, this is the norm for them. And so I think you guys are going to really be the leaders in the community and teach a lot of people who don't have transplants how to really be cautious and make sure. So I think this is a time in which you should rest assured that you've been practicing good habits all along.
Yeah, I think that's kind of the same with our home patients, our home dialysis patients. I think there's that fear of, even if they have to come into the clinic for labs or anything, of what the potential risk is. And we have a lot of patients who call in kind of a state of panic, but utilizing, like I said before, your support and following the same things as Dr. Desai said about with infection control. Everything that you've learned in order to do dialysis at home is what's going to keep you safe out in the world as well, in terms of washing your hands and being extra cautious in terms of infection and protecting that catheter. You're just protecting your entire body at this point. So, and reaching in with your healthcare providers, or reaching out to your healthcare providers if there is this concern and where it's kind of becoming all consuming, the fear that you have, to see if they have any suggestions of alleviating that fear and that concern.
And I can say, as a transplant recipient, as soon as this all started and they started talking about washing your hands and, you know, all of the recommendations, I'm like, oh, welcome to my world. I've been running from viruses, washing my hands, never leaving home without hand sanitizer, you know, running from people with cough and sneezing for over 3 years now. So now everybody just should follow the same guidelines and we'll all be fine. But I do understand the underlying anxiety that some people find with this. But, you know, so I think that's just great advice, that if we continue to be as diligent as we've been taught to be immediately post-transplant, that we're way ahead of everyone else. And, you know, you can't control anything except for yourself, anything or anybody except for yourself and your own environment. So, you know, stay in as much, utilize your support system as well. I'm fortunate to have a support system, and, you know, most of us do. And we just have to know that this is a time we have to rely more on our support system than we may be accustomed to. Thank you. Those were all great answers. Let's see. Another question. I'm on dialysis now and take a lot of medication. Will I need to take more medication after transplant?
Well, I would comment that I think getting in the habit of having a regimen behind your medications, whether that's a pill box or phone alarms, is a great practice in preparation for transplant. After transplant, we do have our patients on quite a few medications. We tell a lot of patients that oftentimes those medications that you were on pre-transplant, you'll likely be on a majority of those after transplant as well. A lot of the kidney transplant is not a cure. It just removes the need for dialysis. So if you have high blood pressure or diabetes before transplant, those disease states will still be present after transplant and will require medications more often than not.
Okay, thank you. I do have another question from Facebook. Margaret is a 2-time transplant recipient who is currently on dialysis. She said she works at a PCP office as a medical assistant. Anything I can do to address HR regarding work? They have declined me to come back to work to answer phones or assist in telehealth visits. So she's currently on dialysis, but she has had 2 transplants.
Okay, and okay, so I'm trying to think where to go with this. So if you've talked to HR and currently not able to, they're not having her come into work?
Right, she says they have declined to let her come back and answer phones or assist with telehealth visits.
Yeah, right now is a really tough time with patients, dialysis patients who are working, and really employer specific, I think, in how they're handling patients if they know there's a risk for a greater infection because of being on dialysis. With our patients, what we have done in terms of if they are working full-time or still having to go into an office, doctors have provided, letters to request that either patients be able to wear masks or work from home due to what's going on. And it just depends on the provider, I think, if their flexibility. I would see if you still want to work and you're able to work remotely, especially if that's an option, seeing if maybe your doctor, talk to your clinic social worker or doctor to see if you're maybe able to get some sort of documentation stating that, you're still clear to work, but remotely, and seeing if that's something that they could set up for you, because you should still be able to have some sort of interaction if they're keeping you on as staff, but working remotely. But I would talk to your clinic social worker and see what they might be able to provide you to speak with, HR, especially if that's maybe where your insurance is coming from as well.
Great, thank you. There's another question from Facebook. What are your thoughts on the effectiveness? This is for the pharmacists, so you guys listen up because this is deep, I think. I'm going to try to say these medication names as best I can. What are your thoughts on the effectiveness of Suvitru versus IVIG to treat chronic antibody medicated rejection in kidney transplant? Currently getting IVIG infusions inpatient, but would like to switch to Suvitru sub-Q injections at home. It would be much more convenient, but I wonder if Suvitru would be as effective in treating the rejection as the IVIG infusion. Thank you for your thoughts.
So I'm going to answer the question in a very broad and general manner, in that even in the context of the treatment of antibody-mediated rejection, we have not really found, the best regimen in terms of treating these transplant complications. For example, our colleagues from Loyola Medical Center may treat their rejection case by using IVIG, and it depends what kind of rejection it is. But here at UIC, we may treat rejection differently. So every center would treat rejection differently. As to the specific drug Suvitru, I am not quite familiar specifically what the drug is, but from what it seems like, it might be the novel agents that's under clinical trial. And so if that is the case, then we're still accruing a lot of information as to how we're going to use that drug in the context of antibody-mediated rejection. Dr. Reticker might be able to give you some other remarks about, treating chronic mediated rejection, particularly with the use of these agents.
No, Ben, I think you summarized it nicely. It's, challenging for us to make a decision without knowing the full clinical picture. But I would say, like Ben said, it's pretty challenging overall to treat chronic mediated rejection. And so a lot of times we want to get a good idea of IVIG, which has been our mainstay for so long to treat, before we consider other drugs. But definitely a conversation I would encourage you to have with your provider. I would also say it might be difficult to get insurance approval of that at-home medication, which might be a struggle.
Good point. Especially if something is still being studied. That can be a struggle. Is it possible to get a transplant if I'm not on dialysis?
I can answer that one. And yes, it is possible to get a transplant if you're not on dialysis. And in fact, in many instances, it is encouraged if your kidney function percent-wise, or if the GFR, the glomerular filtration rate, is less than 20 mils per minute, you would qualify for transplantation. But that doesn't mean that you need dialysis, because when we talk about dialysis, it's usually when your function is maybe less than 10 milliliters per minute and you're symptomatic. And so it is certainly encouraged that if you qualify for transplantation, that you get yourself on a wait list. So visit the centers, get the education. And if your nephrologist, your general nephrologist, is taking excellent care of you and can maintain that level of kidney function for the time needed to get a deceased kidney transplant, which in Illinois averages about 5 years, then you may come up for a transplant without ever having been on dialysis. The other way that we can pursue that, though, is through living donation. And so many centers would encourage what we call preemptive transplantation, which means that you have very diminished kidney function that may be affecting certain aspects of your life, but you have a qualified living donor and are not yet on dialysis, and then we would move forward with transplantation with that living donor candidate and yourself. And so that would be transplant preemptively without ever being on dialysis or requiring dialysis. And that is certainly acceptable, and in fact, it's encouraged because our mortality rates, or our chances of death in 5 years on dialysis, are so much higher than having not been on dialysis.
Thank you.
If I could add, I would certainly agree with what Dr. Desai said. Actually, the best long-term results with kidney transplant are in patients who have not been on dialysis. Nevertheless, that doesn't mean that you go out and get a transplant the minute you're told your kidney function is not normal. It's a balance between becoming symptomatic and approaching the time when a transplant would be helpful. And this is a decision often made in conjunction with the nephrologist and the transplant program. But so the answer is yes, you can get a transplant before you go on dialysis. And if you're fortunate enough to do that, to obtain a kidney under those circumstances, the results are usually quite excellent.
Thank you both. That's great information. Here's another question. I've been on dialysis for a few months, and I haven't really talked to the social worker. What can they help me with?
Well, the social worker should definitely be checking in with you, but the social worker can help with a broad range of things on the dialysis side. So we definitely help with insurance-related matters, whether it be access to insurance, navigating Medicare as a dialysis patient, Medicaid, if there's at risk, if you have insurance and potential loss of coverage, navigating that. We also help with navigating if there's a financial strain based off of dialysis, whether it be connecting you with a fund or grant for helping with premium payments, or the cost of even getting to dialysis via transportation. A lot of social workers help with transportation to and from dialysis and getting you there. And if there's a way other than taking a cab or Uber and finding something that's not going to cost you anything, whether it be, or cost you very little, so whether it be setting you up with PACE transportation or transportation through your Medicaid, if you have that. It's, patient to patient, obviously. But then also helping you with adjusting to dialysis in general. If you're struggling with this, new way of life and a new routine, ways to cope with it and move forward. But also in the transplant side of things, getting you connected to a transplant program, if that might be something that you're interested in, educating you about the centers within Illinois, depending on insurance, if you're eligible outside of Illinois. there's a whole plethora of things that we can help you with, but making sure that if you haven't seen the social worker at your clinic, to, you know, ask one of the nurses or PACS facility managers so you can get some time with the social worker, because they may be able to help you with a lot more things that you would think of.
Okay, thank you. Thank you so much. There's a question from Facebook. This is a pharmacy question. Do some beta blockers have a negative effect on GFR?
I'll start off. So no, we do not see that beta blockers are associated with causing harm to the kidney. There is one beta blocker in particular, atenolol, which is renally excreted, meaning it goes through the kidneys to get out of your body. And sometimes those two things can be a little confusing. Ben, did you want to add something?
I pretty much would echo what the Dr. Reticker said, that this specific beta blocker called atenolol, it becomes an issue for our patients who have bad renal function, because then what happens is that, you know, they're unable to clear the drug, and as such, if that occurs, we're putting our patients at a higher risk of developing side effects from that particular beta blocker, and those side effects include the possibility of, for example, fainting because of having low heart rate in layman's language. So it's not per se the atenolol affecting your kidney function, but more so that we're putting you at a higher risk of having side effects from that specific beta blocker due to an impaired renal function.
Thank you. Another question from Facebook. I'm a kidney recipient, 24 years out. I drive vehicles as a transporter. Should I return to the same work when everyone else goes back to work? Dr. Jensik, you have a?
Is this person now on?
So the person is a kidney transplant recipient, 24 years out. So they've been living with their transplant for 24 years. They drive vehicles as a transporter. And the question is, should they return to work, to this same work, once the, you know, stay in place, is over?
So I assume now they're not working just to be socially isolated and avoid contact. Am I right?
I would think that's correct, the way it reads.
I don't think there'd be any reason why they couldn't go back to work. I think some safeguard would be important. Wear a mask. Insist that the people you drive, I assume he drives individuals or patients, they all wear a mask. Make sure that the car is appropriately wiped down and things like that. But I don't see why they couldn't go back to work.
Okay, thank you. Let's see. Is it possible to stop going to dialysis if I change my eating habits and physical activity?
So I can take that one. So, you know, renal failure is a complicated thing. And as a nephrologist, there are times where we do see patients who have been temporarily on dialysis and then they come off of it, but that's usually an injury that we say is acute. And so it's because maybe they got sick or they got dehydrated and then your kidneys would rebound. When you're at the point that you're on chronic dialysis, it is certainly that your nephrologist has done all the workup, assessed your medical health, looked to see if you had long-standing high blood pressure, diabetes. Those are the number 1 and 2 cause of kidney failure in the United States. And it is highly unlikely that with changes in diet and exercise and care that the kidneys would recover, because they have been injured to the point where that dialysis has been required. If you have chronic kidney disease, that may change things a bit, because high blood pressure and diabetes are diseases that affect your kidneys over years of time, unless it's something all of a sudden excessive or malignant that's caused that problem. And so in those instances, changing your health, watching your diet, exercising, losing weight, all of those things would help to lessen the hypertension and the diabetes burden, and that could fix your kidney problem for a longer period of time. But being on dialysis and coming off is a rare thing if it's from a chronic injury that's not going to correct itself.
Okay, thank you. Looking through a lot of these questions we've answered with our discussion about transplants and, you know, what's going on with COVID-19. Here's a question. Since transplant patients are immune compromised, if they contract COVID-19, will they require hospitalizations and have major complications?
Well, I would answer that, and certainly if they contract COVID-19, they're at increased risk for complications. And so we have patients who are COVID-19 positive who are relatively asymptomatic. And I think, as Dr. Desai mentioned, those patients are watched very carefully at home, with almost daily phone calls from people from the transplant office. But it is a serious risk if being immunosuppressed adds a serious risk if you get COVID-19. And so constant communication with the transplant team is mandatory, but it does significantly increase the risk. Dr. Desai, agree? I assume you probably agree.
Yes, I would say that you are in that at-risk population. Some patients, they have just a cough or malaise or aches and pains, and just as Dr. Jensik said, we call them every day to make sure they're not progressing in that disease state, but watching their symptoms very closely. Those have come to the hospital, you know, they're all in different situations, and I think that just also speaks to your immune system and how you've handled things before as well. So every individual is going to have a different experience when it comes to this disease process, but being immune suppressed does put you at a higher risk than the average individual.
Okay, thank you. Thank you both. Terry from Facebook says, thank you, Dr. Jensik, for your advice. Let's see. Here's another question. What are the top 3 rules I should abide by to prolong my transplanted kidney's life?
Well, the first is to maintain a lifelong relationship with the transplant program or a transplant program. Many times patients are under the illusion that, well, I'm 3 to 4 years post-transplant and I don't have to follow up with the transplant program. That's not a good idea. Obviously, if patients move out of state or relocate, they need to follow up with some sort of a transplant program. That's the most important. The second is absolute compliance with transplant medicines. So we heard a previous discussion about chronic antibody-mediated rejection and the fact that there are not very many therapies for that. And one of the causes for chronic antibody-mediated rejection is not being completely compliant with the transplant medicines. And so what happens if patients miss doses? There are low-grade subacute rejections that start, and they gradually lead to chronic injury to the kidney and loss of kidney function and return to dialysis. So absolute compliance with the medication. And the third is general healthcare maintenance. In other words, either through the transplant program or with primary care physicians, good control of blood pressure, good control of diabetes, common sense general health things that we're all supposed to do, reasonable exercise, weight control, things like that. I think if I had to list 3, that would be the top 3. Dr. Desai, would you put them in a different order, or would you add anything else?
No, I agree 100%. Those would have been my top 3. And the only thing I would add as part of your general health would be keep up with your cancer screening as you need. So, you know, pap smears, mammograms, colonoscopies as we age. But I 100% agree with that order. I think that's very important.
Great, thank you. Another question, does everyone post-transplant take lots of medication?
Everyone post. Say that's kind of dependent on your disease state. So whatever led you to need a transplant can kind of be a good predictor of what medications you'll require after transplant. I would say Monica can probably emphasize this, how at first there might be a lot of medications in those first 6 months, but things get a lot easier once you make it through that first 6 months. Even the first 3, there can be some big milestones associated with those. So I would say expecting, 8 to 10 medications is not unreasonable, and in some cases more. But knowing that if you continue to take your medications as they're prescribed, that's how we start to peel back, is by taking them the way you should be taking them.
Yes, I agree with you. Immediately post-transplant, when I was discharged from the hospital, I went home with a bag of medication that was like this, I don't know, must have been 17 prescriptions. But every time I went to clinic, so twice a week initially, medicines dropped off the list and dosages decreased. So up to the point now where I really only take 3 prescriptions. So, it's a myth that you take a lot of medication for the rest of your life if you get a transplant. Most people, when I talk to people on dialysis, I say, how many pills do you take now? And then I tell them how many I take, and it's like, I take less than them. I take less now than I took when I was on dialysis, especially when you count in the phosphorus binders. So yes, thank you for that. Okay, so our time is moving along. We're at 6:05. I think we've answered most of the questions, and we've really done a great job of covering a lot of ground here. At this point, I think I would just ask if each of you want to maybe just give one bit of advice that you would give for patients who are watching and who will also watch this. Actually, right now, let me just let everybody know, this is the last of our series of what we call Living with Kidney Disease and Transplantation, which is normally an in-person workshop that lasts from like 8 a.m. to 1 p.m. And we have lunch, and we have continental breakfast, and all of these conversations happen in person, but due to COVID-19, we had to switch virtually. So I want to let everybody know what sessions are available. Anyone who has not had a chance to watch the sessions that led up to this last session, we had exercise in CKD, we had immunosuppressant updates, and also I've got a kidney, now what? So those are available to be viewed at any time on our website. And then we had, this is the third of 3 live panels. The first one was Ask a Dietitian. So for those who had questions that we didn't answer regarding diet and nutrition, feel free to watch that one. I think you'll get all your questions answered, because we had a CKD dietitian, we had a dialysis dietitian, and we had a post-transplant dietitian. So they really covered a lot of ground. And then we had our patient panel, which was yesterday, and it was phenomenal. We had a dialysis patient, a transplant recipient, a couple of living donors, and someone who's living with CKD and has changed their lifestyle to prevent the progression of chronic kidney disease. So there's lots of information, and the beauty of the fact that it's done virtually is it's there for everyone to enjoy at their own convenience. So just wanted to call everybody's attention to that. And then just ask the panelists to leave us with one last thought before we close out. So we'll start with you, Brett.
Sure. So actually, I just wanted to kind of add to a question that was brought up about exercise and nutrition, about trying to get off of dialysis. Like Dr. Desai had spoke, that's very, very rare, if at all. But doing exercise and appropriate nutrition can help you possibly get on a transplant list, which then would hopefully get you off of dialysis that way. So that's probably the best way to incorporate exercise and a better nutrition into your lifestyle, is trying to get onto the transplant list, and that way. But just if you are, whether you're on dialysis or whether you're CKD non-dialysis, trying to incorporate better lifestyle choices, exercise, better nutrition, can help prevent disease progression. Even on dialysis, you can have a little bit more healthier life, better physical function, quality of life with exercise and nutrition. If you're interdialytic, weight gain's not as much, less cramping, less fatigue, things like that. So it's kind of a, help you out more of the quality of life than anything. We're not doing exercise is not going to cure kidney disease, so just make things a little bit more bearable for you. So that would just be my kind of biggest thing. Try to start small. If you're not active, try to get active as much as you can so that you can have a better quality of life.
That's great. Thank you, Brett. Grace?
I would say to connect dialysis, the dialysis side, to transplant. If you are on dialysis and looking towards transplant, use dialysis as a way to practice for having a transplant. So going to all of your treatments, do not skip treatments. I know it can be easy when you start to feel good to skip, but go to your treatments, get in the habit of taking the medications and utilizing your healthcare team, because that's exactly what you're going to need to do once you're transplanted. So really get in a good habit while on dialysis so that you can then get to the transplant point. But also utilize your social worker, because there are so many resources out there for dialysis patients. So just asking questions so that they can connect you with whatever it may be that might help you at that time.
Great, thank you. Anesia?
I would really like to echo what Grace said. I think that's great, really getting into the habit. But with that, like finding what works for you, and that what works for you, also remember that it should include support of others, and that this is support from your providers and your pharmacists, and it's a team effort, your social workers, everyone, but also your family and friends, and being open with them. And transparency is really key for us to all work together to help you. And really knowing what works for you. We say pillboxes, but maybe a pillbox doesn't work for you and you feel phone alarms do, or an app, or whatever it is, but really identifying that and letting others help you identify what works for you.
That's great, Anesia. And I just say, from a personal standpoint, I use all of them. I have a pillbox, I have an app, and I have alarms. I'm not going to miss the medication. Ben?
From a from a druggist perspective, I cannot emphasize it enough. And as Dr. Jensik and as Dr. Desai well articulated earlier, it is very, very important for transplant patients to take their medications, particularly the anti-rejection medications. Clearly, the number of medications is an issue. The fact that a couple of our viewers asked, how many medications on average our transplant patients take. I must emphasize that the anti-rejection medicines, once again, as an anti-rejection medicine, these medications are lifelong and life-saving medicine. And so we advise our patients to take these medications as prescribed. If you're having issues, troubles with your medications, as these medications are not benign, we are here for you. Your transplant nephrologists are here for you. The pharmacists are here for you to assist you, to help you offset these side effects, whether or not we need to make those adjustments, for example, or figure out some solutions for these side effects to the medications. I would also like to take this opportunity to give more so like an advertisement for our transplant patients to visit American Society of Transplantation website and learn about this immunobill, which attempts or which aims to extend Medicare coverage for your medications. And with that, I'm going to end my piece.
Thank you. Thank you so much. Dr. Desai?
So, I'd like to say that kidney disease is a complex disease. And if I could argue, it's probably one of the most complex diseases, and it has stages. There's chronic kidney disease, there's dialysis, there's transplantation, and you have to navigate all of them. But there are so many resources for you in each of those stages to help get you the education that you need, the support you need. It's complex, and you see this panel here today in front of you. Everybody has their niche, their specialty. They know how to advise you. They know what kind of care to provide you. And it's something that you need to just embrace. And I encourage that you embrace it so that you can stay on top of it on yourself. Ask these important questions that you're all asking today, and just continue to kind of move along that kidney disease process. I'm a nephrologist because I love kidneys. And so my goal is to make sure that if you're in any of those stages, you're getting the best care possible. But transplant is really what I do. And if that's where you are, then that's a liberating step too, because it gets you off dialysis. You've gone through those stages of kidney disease, and then, as everyone has said, take your medicines, comply with your doctor, stay connected with your center, your nephrologist, all those caregivers, and just keep that motivation to educate yourself and use these resources, these wonderful resources that we have and that we all provide for you.
Thank you so much. I mean, I am just so blown away by all of you being present here with us and taking this precious time to give all of this knowledge, share all this knowledge with our patients and with me. We all are very impacted by this, and yeah, I can't thank you enough. So I think Dr. Jensik is having a little, having some connection trouble. But I also want to thank our team who put this together, who had to shift on the drop of a dime to, undo all of the in-person planning that we had done and switch to virtual. So we've got an amazing team at NKFI and great leadership. And so I'm excited to be a part of that team, as this part of my journey is really a blessing. And just so happy that we were able to pull all this off. It's exciting. So that really concludes Living with Kidney Disease and Transplantation. It includes this. It concludes this session. I want to thank you for tuning in this evening. And again, I want to thank our sponsors for making this virtual session possible. Our sponsors again are Baxter, DaVita Kidney Care, CareDx, Fresenius Kidney Care, Gift of Hope Organ and Tissue Donor Network, Loyola Medicine Transplant Center, Northwestern University Medicine, Rush University Transplant, and UChicago Medicine. As a reminder, this session and all the others that I mentioned were all recorded, and you can watch them all again later in the week by going to our website at nkfi.org. So thank you all for joining us, and everybody have a good night.